This is part 3 of chapter 20, Variations of Nursing Interventions for Pediatrics. So on medications, we can give rectal meds just like you can with adults, but remember everything's smaller, so you're probably going to use your pinky instead of your index finger to insert it, and you're not going to go as far. And just like with adults, if you're vomiting and can't take something orally, rectal works, but it is an awkward route to go. And eye drops, ear drops, nose drops, we can do these on kids, and we do. You're not likely to get a child to hold their head back and let you really pull down on the lower lid to make, that nice little pocket there to drop it in. So it's easier to have them lay flat and then drop it in. On an infant, they're going to pinch their eye close tightly as soon as you try and pull down on that lower lid. So if you drop the drop right on the inner canthus of the eye, when they do open their eye, it will run into it. Intake and output. The smaller something is, the more precise you have to be. So intake and output on children has to be more precise than it does on adults. And on neonates, it has to be more precise than on children. So be very accurate, measure things down to the ml. You'll see up in NICU, they even use decimal points. If they take out, 2.3 mLs of blood for a blood draw, they chart 2.3. So be very accurate. We weigh diapers, we weigh them in grams and chart them in mLs, because that's the beauty of the metric system. A gram of weight is a ml of volume for water, and urine is essentially water. If a child is not eating, they must get IV fluids. An infant can only go a few hours between feeds. They can't go more than that without getting fluid. A child can go a little longer, but not as long as an adult. So if we have a child NPO, make sure they're getting IV fluids. And IV fluids, we use the same sites as adults, plus we use the lower extremities, and we can use the head on a neonate. We can also do interosseous, so if we can't get an IV anywhere else, they can puncture right into the marrow of the bone. You can give a lot of fluid very fast into that. It's kind of an emergency site. You'll probably only see it in the ICUs. And then a surgical cut down. If we can't get an IV in, it's essential to get it. The surgeon can make a little incision, or the physician makes a little incision on the skin so that they can see the vein, and then the IV is put in. So here are the sites that we use, the same ones in the arms that we use for adults, plus the legs and the feet, and this frontal vein, which is a wonderful vein. It's really big and strong. And then there's a few choices around the ear. These aren't as good just because then you can't let the child put their head that way, and you don't want them laying on it. Managing IVs, you can imagine with kids, things get bumped and wiggled and picked at, and we have trouble with keeping them. We don't have a policy at Children's that an IV has to be taken out every so many hours, but they rarely last longer than that 72-hour thing that you're used to with adults. So we are watching them for infiltration and extravasation, especially if you have a medication that is very damaging. You're going to be watching. What you're going to see for protecting IVs at Children's is arm board or foot boards, just like this. And then we'll also wrap the site in Curlex or put burn netting over it, because if it's out of sight, it's out of mind. It's amazing. They do have devices like this as well to protect it so it doesn't get banged. But what you're going to see at Children's is the arm boards. So inhalation therapy and oxygen therapy. There are different ways to give oxygen. There's the plastic hoods that are used on neonates. We can do nasal prongs, but they come in different sizes. Think about what size your child is. Oxygen masks, oxygen tent, and what we've been using a lot of recently in the last few years is high flow nasal cannula. So here's a picture of a baby under an oxygen hood. It's got a little monitor under here to show exactly what the oxygen level is. And here is the oxygen tent. We sometimes use these for continuous albuterol. We used to use them with croup and just blowing in cool mist. We're not doing that routinely, but you may still occasionally see that. Oxygen, like anything else, is not without risks. On neonates, high levels of oxygen can damage the retina and cause blindness. In the ICUs, they try and lower the oxygen percentage as quickly as they can, even if the child's on a ventilator and they're using a fair amount of pressure or volume for each breath. They're trying not to use 100% oxygen if possible. If somebody's on oxygen, we want to make sure we have a pulse oximeter on. Up in the ICUs, they have little transcutaneous monitors that go on the skin where they can assess the oxygen concentration of the blood and also the carbon dioxide. They also in the ICUs may have an end-tidal carbon dioxide monitor. If they're intubated, it's between the ET tube and the ventilator tubing, and it is monitoring carbon dioxide. You'll see some kids with trachs. All of our trachs at Children's are the disposable ones. They don't have the two pieces like we have in Skills Lab. They're just single, and you may see a child with one. We do this a lot where we put an extension on. This is not really have any function except to get the trach away from the child's chin, because kids don't have much neck and we don't want things, rubbing on their chin. This is an artificial nose. You could put this right straight on the trach without this extension. It does exactly what your nose does. It catches dust and particles, and so it filters the air as you breathe in. And then when you breathe out, it catches the humidity, uses that humidity or that moisture to humidify the next breath. So it does basically what your nose does, and we call it an artificial nose. You'll see kids get postural drainage and CPT at Children's. Some will get it manually where we're actually physically banging, percussing the chest. Most will get it with a vest. They put a vest on and it does this pneumatic percussion, and kids say it feels good. It feels sort of like a massage. And then that is to break up and loosen up, mobilize those secretions. Then we want them to cough it out. You will see kids in the ICUs or Apollo and rehab with artificial airways. Up in the ICUs, they'll have endotracheal tubes. At rehab or Apollo, it's going to be tracheostomies. One difference just to note, we rarely use cuffed tubes. They're almost always uncuffed. Our book says on children under 8. The anatomy is a little different, and so you don't need the cuff, and in fact, we don't usually use it. So when we do have a child with a trach, it's below the vocal cord, so we've got to think about their development of speech. Also think about suctioning. Adults, I know you were taught to go deep. We try not to. We go right to the tip of the tracheostomy tube. We really don't want to go down and hit the tissue. If you're continually rubbing and pulling on that tissue by suctioning, you're going to irritate it. You're going to make more secretions. You're going to have to suction more. So we put on the head of the bed exactly how deep to suction, how many centimeters, and our catheters all have little marks on them in centimeters. So we're going to the tip of that trach tube but not beyond. And we want that trach tube to be tight enough that it doesn't come out, but not so tight as to do any damage or cut off blood flow. So the policy is one finger. You should be able to get one finger underneath of it. Chest tubes, hopefully you'll get to see chest tube. while you're at Children's. Up in the ICU, anyone who's had thoracic surgery, we put in a chest tube afterwards. On Apollo, which is our respiratory floor, you will often get to see a chest tube there. They don't have chest tubes all the time, but over the course of the semester, you'll probably get to see one. They're just like you've seen with adults. They're 3-chamber. The one thing that's different at Children's, ours have dry section. So our section is controlled by turning a dial. It's still hooked up to the wall section, but rather than a chamber full of water, there's a dial you turn so you don't hear that bubbling. Feeding. We're going to have kids with NGs and OGs and gastrostomy tubes. Up in the ICU, they really like to put down NGs into the jejunum, because if they're intubated, we don't want them to reflux and aspirate. So we like to go deeper. They would have to reflux all the way through the duodenum and the stomach in order to reflux and then aspirate. So if you're going jejunal, you have to do a continuous feed. You cannot do a bolus feeding because there's no stomach to hold a big mass of feeding. There is no place to hold it. Where into the stomach, it might be either continuous or bolus. And measuring for a tube is the same thing you were taught with adults, that nose to earlobe to xiphoid process. Whoops. And when you're putting one in, you're going to measure it. You're going to need that tape measure to measure lubricant, that water-soluble lubricant. And then if you're putting it on a pump, you'll need the pump. And when you're giving a child a feed, especially if you're giving a bolus feed, treat it like a regular feed. Hold them, give them a pacifier. Eating should be a pleasurable experience, so make it that way. Even if we're giving them an NG feeding, we really want them to associate their stomach filling up with good feelings. We don't want them to develop an aversion to feeding and to food. You'll see G-tubes at Children's. This is a standard gastrostomy tube where most of the time you'll see the Mickey. Both of those have some granulation tissue around. You should not have this red. That's not ideal. TPN. You're going to see kids on TPN. If you're on TPN, you have to have a central line, and so we've got to teach family the care of that. Lipids are fats. TPN has everything except fat in it, so between the two together, then you truly do have total parenteral nutrition. And hopefully you'll get to see some babies with ostomies. And our ostomies always are really nice looking compared to adults. When I've seen adults, I'm always surprised how funny shaped they are. They aren't round. They don't have that nice, centimeter or two raised above the skin. So anyway, our ostomies tend to look better, but get a chance to see one because we do have babies with those. And care is, we're still keeping a bag on it, emptying the bag, making sure we care for the skin around it, making sure that hole fits, the hole in the wafer fits well around it so that we aren't getting, especially if it's very loose and acidic stool, we don't want it irritating the skin, but we don't want that hole in the wafer pinching off the skin and doing any damage.